we go. Okay, so I'm really glad to be back with you this evening. My name is Katie Higgins. I am an advanced clinical practitioner and a health visitor and a registered nurse as well. The majority of my experience has been in primary care and in a community setting. More recently, I've worked in a community looking after vulnerable adults within a neighbourhood team. So I've got lots of experience when it comes to adult safeguarding and also the multi-agency working and the frameworks around vulnerable adults in a community setting. I've also got extensive experience in out of hours, worked in out of hours for about 15 years as well. So the aims and objectives for today's webinar is to give you a brief overview of adult safeguarding and types of abuse, to gain an understanding of the Care Act and the 6 core principles for adult safeguarding, explore the factors which may influence on raising concerns, and have an understanding of community teams and adult safeguarding in relation to complex cases. And to finish off, I'll just briefly go through domestic abuse and how to have those difficult conversations. So just to start off really, so what does safeguarding mean? So safeguarding means protecting an adult's rights to live in safety, free from abuse and neglect. It's about people and organisations working together to prevent and stop both the risks and the experiences of abuse, while at the same time making sure the adult's well-being is promoted, including their views, wishes, feelings and beliefs on deciding on any action. So the adult is very much centre to the safeguarding process. We really need to be linking in with them, asking their views and their feelings when we go down that kind of safeguarding procedure, and to get further support and help. So the aims of safeguarding is to stop abuse and neglect where possible, prevent harm and reduce risk of abuse or neglect to adults with care and support needs, safeguard adults in a way that supports them in making choices about how they want to live, promote an approach that concentrates on improving lives for the adults concerned, provide information and support in an accessible way to help people understand the different types of abuse, how to stay safe, and what to do to raise a concern. And I think this is really important as well. And what we do know with the Mental Capacity Act is people are allowed to make unwise decisions, and people may choose to stay in abusive situations, and may not want to raise concerns around abuse. And it's very much about educating our patients, making sure that they've got all the information available to them in a way that they can understand. And, you know, hopefully in the future, they may want to leave that situation. It's also about kind of raising public awareness so that communities and professionals play a part in preventing, identifying and responding to abuse and neglect. So very much that community approach as well. So briefly, just to go through the types of abuse, there are 10 different types of abuse, and I'll just go through these quite quickly because I'm sure you're all aware of them. So we've got things like physical abuse, which includes assault, hitting, slapping, pushing, misuse of medications, unlawful restraint, neglect and acts of omission. So this may be ignoring medical, emotional and physical care needs, withholding the necessities of life, such as medication, adequate nutrition and heating. Domestic abuse, which I'm going to come back to later on towards the end of the webinar, which includes psychological, physical, sexual, financial, emotional abuse, and includes things such as forced marriage and coercive control, which was newly added to the Domestic Abuse Act in 2021. Psychological and emotional abuse, which includes things such as abandonment, blaming, controlling, intimidation, cyberbullying and isolation. Sexual abuse, which includes rape, indecent exposure, sexual harassment, sexual assault, or being pressured into consenting. We've got things like human trafficking, modern slavery, which is classed as a type of abuse, organisational abuse as well, so neglect and poor care practice within an institution or a specific care setting, such as a hospital. Now, many of you might remember the Francis report, which was looking into that organisational neglect within a trust. More recently, I think last year, there was a talk of a mental health trust around the centre of England, which were kind of investigating claims of this organisational neglect. And I think there's other things that are due to come out around the midwifery scandal and that type of thing. Radicalisation, that's classed as a form of abuse when it involves a vulnerable adult who has been exploited. So a group of terrorists target that person and involve them into terrorism activity. We've got discriminatory abuse, so things like hate crime, harassment on race, gender, age, disability. Self-neglect, which again is always a difficult one, especially for social workers, with the patients that they get referred in around self-neglect and hoarders. And again, that person may choose to stay in that environment, but as long as we've kind of given them information, given them links for further support and help, maybe got the fire brigade involved to kind of come and have a look at the property, see if there's a safe route out of the house, if there was a hazard, because hoarding can add to that fire risk. It's about supporting that individual to live in their own home if they have capacity and don't want to address the situation. And financial abuse as well, so things like theft, fraud, internet scamming, coercion in relation to an adult's financial affairs or arrangements, including things such as will, property, inheritance, or financial transactions. So lots of different types of abuse that can happen, but it's really mindful to be aware of that abuse can happen in any setting. So not just in the home environment, it can happen in a care home, a hospital, in sheltered accommodation. And I always remember when I was a newly qualified staff nurse, I think I'd only been qualified maybe 2 or 3 weeks, and I had a bay of patients, was looking after my patients, went off on my shift, left them with the healthcare assistant, came back from my shift, and she went on her break. And one of the patients reported to me that she had physically assaulted him and had bruises and marks to show that had happened. And it was a real eye-opener to me, being so newly qualified and so new in the field, that this thing could actually happen right under my nose in a hospital environment. So, abuse doesn't just happen at home, and it can happen in other settings, and we need to be really mindful of that. They're absolutely not safe from abuse if they're in a hospital environment or in a care home, for example. So if that happens to you where you get allegations about professionals, it's about kind of following your own procedures within your organisations as well. So some organisations you need to follow the whistleblowing policy. Some organisations will have specific policies about what to do if there's an allegation about professional. But getting that senior advice and support and following your own protocols. And again, adults can be at risk of harm from those who are caring for them. So it could be a member of staff, a carer, or a volunteer, or a professional. Now, when we talk about adult safeguarding, we talk about vulnerable adults a lot. So I thought it was quite beneficial if I just define what a vulnerable adult might be. So a vulnerable adult is somebody who has care and support needs, who are at risk or experiencing neglect or abuse, and because of their care and support needs, are unable to protect themselves from the abuse or neglect. The NHS defines a vulnerable adult as a person over the age of 18 and again are unable to take care of themselves or protect themselves from exploitation. Now, many factors may influence on whether somebody is vulnerable or not, and it may be that they've had vulnerabilities in their childhood, which may have negatively impacted them later on in life. Now, there is something called the ACEs, the Adverse Childhood Experiences. If any of you are unsure of that term, I definitely recommend having a look at that, or doing some CPD around kind of the ACEs, because sometimes if you've got those risk factors in your life, so it may be that you've gone through a parental divorce, it may be that your parents were substance misusers, you may have had domestic violence in the home, for example. There's a list of different things which class as an adverse childhood experience. If you've had 3 or more of those things happen in your childhood, the kind of the research and the literature shows that that can have a negative impact in adult life and make you more susceptible to being a vulnerable adult or experience abuse yourself. So again, we just need to be mindful of that. And also, if somebody's not got protective factors in their life, so if we think of the Maslow pyramid, and if people don't have a stable household, they haven't got a stable income, they may be struggling with the cost of living crisis, struggling to get by with the bare necessities like food, heating, shelter, then that makes them more vulnerable than other people in the society as well. And they're more likely to not be able to protect themselves from abuse because they're trying to get those basic needs met. So lots of different things can contribute to really what can make a vulnerable adult. So we have a professional responsibility. So all staff who work in health and social care play an essential part in ensuring children, young people and adults and their families receive care and support they need. You may be the first person to be aware that an individual or a family are experiencing difficulties. And we do have that duty to share concerns if you think that an adult is at risk, and it's a statutory requirement of our roles as well. So the main legislation around safeguarding adults is the Care Act of 2014. And the Care Act of 2014 sets out a statutory responsibility for the integration of care and support between health and local authorities. Now, some of you may have seen this in your day-to-day work, and I very much saw that when I worked out in a community model, this notion of care and health being under one roof and having monthly liaisons or meetings to look after the communities that they serve. And I'm sure some of you might remember Sure Start centres as well. That was kind of the beginning starts of kind of integration of that social and kind of health services. So it's part of the Care Act. NHS England and clinical commissioning groups are working in partnership with local neighbourhood social care services. So again, it differs from where you work and where you are in the country. Different areas have different models that they utilise. So you may have a neighbourhood model where you have kind of social care within health. You may have enhanced care teams that kind of work very closely with social care for vulnerable adults. You may have kind of primary care networks that work quite closely with social care to try and help serve the communities that we look after, that integration, those integrated care systems. Local authorities have a statutory requirement for safeguarding in partnership with health, and they have a duty to promote wellbeing within the local communities. So your local authorities, social services have that statutory responsibility for safeguarding our adults. So the Care Act of 2014 also set out 6 principles for professional working in relation to safeguarding. And these 6 principles that we should be encompassing in our practice are things like empowerment, so supporting people to make their own decisions and supporting people to give informed consent. Prevention, for us all to act before harm actually occurs. Proportionality, so the least intrusive response appropriate to the risk presented. So I'll give you an example of this. So when I worked out in a community in the neighbourhood service where I was an advanced clinical practitioner, I was referred in a man who had Parkinson's and his wife was main carer. They were concerned because he had a significant decline in his health and didn't feel that wife was the best carer to look after him. So I was in a position where I could really get to spend some time with the family. I had quite long visits, and I could really get that rapport going and that therapeutic relationship and unpick the case. And what happened was the wife was an alcoholic, and she was not administering this gentleman's Parkinson's medication on time, and sometimes would forget some days. And as a consequence of that, he had a decline in his symptoms. Now, going back years and years ago, it may be that social services would have come in and would have removed him and put him into a care setting, and taken over the full control without actually kind of asking his thoughts and his wishes and that type of thing. But actually, he wanted to stay at home with his wife. He didn't want to go into a care setting, and they agreed to have some additional help. So have a carer come in and administer the medications. And that's an example of the least intrusive response, working with your family, finding out where the problem is and trying to do the less restrictive option. And just by having that carer in, that was a little bit of support for him and her as well, in regards to his medications. His Parkinson's improved, and we also got her involved with local agencies as well to see if we could tackle this substance misuse. The fourth principle is protection, so support and representation for those in greatest need. Partnership working, as I said earlier, that those local solutions through services working with their communities, so social care and health, or voluntary services as well, which are also crucial when it comes to safeguarding. And accountability as well, so making sure that we're accountable in our day-to-day practice and we've got those transparency in delivering safeguarding. Okay, so what I thought I would draw your attention to also in the Care Act is something called Section 47. So under Section 47 of the Care Act, a local authority has a duty to make inquiries in a case where it has a reasonable cause to suspect that an adult has a need for care or support, is experiencing or at risk of abuse and neglect, and because of those care and support needs is unable to protect themselves from either the experience of abuse or neglect. So the purpose of a safeguarding inquiry is for the local authority to clarify matters and then decide on what course of action is required in order to protect the adult in question from abuse and neglect. Section 42 safeguarding inquiries are carried out sensitively without delay, keeping the wishes and best interests of the person concerned at the centre, and people can participate in the safeguarding process as much as they want. So an example of this would be if you're out or maybe doing a home visit, or you're out on the road and you were going to see Mrs. Jones, for example, and she's an 85-year-old lady, and you go in the house and you realise actually she's not coping very well. She's in quite poor, quite unkempt. She's not had anything to eat or drink all day, and she doesn't know where her medications are. She would be referred into social care, and then Section 47, so a safeguarding inquiry would be carried out to do a full assessment to see how they could safeguard that individual. So that's an example of a Section 47. So often social services will say, this lady needs a Section 47. We're going to do a Section 47 inquiry. Sorry, 42 inquiry, not 47. 42 inquiry, and that just means that they're going to do that further assessment on that patient to see what their health and social care needs are, and if they can put any additional support in place for that person. So I thought it was really important as well, just to highlight you to the statistics around elder abuse. So the World Health Organization has published some literature recently about this concept of elder abuse, and it's reported about 1 in 6 people 60 years and older experienced some form of abuse in the community during the past year. And what they found is that the rates of older abuse have increased since the COVID-19 pandemic. Older abuse of older people can lead to serious physical injuries and long-term psychological consequences. So if you imagine, we've got fragility, bone mass bone density is thinner and that type of thing. So they're more likely to have fractures and that type of thing than somebody younger. And older abuse is predicted to increase as many countries are experiencing a rapidly aging population. So the WHO has found 1 in 6 people over 60. I would debate that the levels are probably higher than that, because we know a lot of our older people suffer from things such as dementia or Alzheimer's. They're unable to communicate or report the abuse that's happening. So again, I don't feel like the statistic is accurate. And also, I think that older population don't always come forward when abuse is happening. There's a lot of shame with abuse as well. A lot of older people are socially isolated. So I actually think the figures are higher than this. And during the pandemic, what I found when I worked out in community is that a lot of the older population developed this kind of notion of deconditioning. So they were isolated, they weren't able to go out and do the things that they normally did, like go to the shops or go to the post office. And a consequence of that, they had a kind of reduced muscle mass and became frailer quicker, to moved up that frailty score. So I can see that in the COVID pandemic, we probably had more of an increase in dependence, again, which would impact on the rates of elder abuse. So there are some risk factors which make you more likely to, elders more likely to experience abuse. So things like social isolation. Again, that is a risk factor to make you more likely to experience abuse. You've got no family members or friends around, no one to report it to. Cognitive impairment, so unable to report the abuse that's happened. Poorer mental health, so we know that the older population will more likely have that chronic disease and those comorbidities. And again, having a comorbidity has a massive impact on psychological health. GPs are getting much better now at screening patients with chronic conditions for mental health conditions as well. But the likelihood is if you've got a chronic condition, then you will have some mental health needs around because of your chronic condition. And if you think of the older population, if you've got 2 or 3, you've got COPD and heart failure, and you're already experiencing some anxiety over breathlessness, and that type of thing, that can impact on your dependency and your increased frailty scores as well, and that type of thing. Patients with dementia are more likely to use physical violence and lash out. And again, if a caregiver is looking after somebody with dementia who's quite aggressive and that type of thing, then they're going to get to the end of the tether sooner. So that makes them more likely to be victims of abuse from a caregiver. And again, intensity of illness, the more dependent you are, the more likely it is that it's a higher risk factor from experiencing abuse from a caregiver. So when we think of our caregivers for that older population or our clients with additional needs, there are some risk factors in what makes that person more likely to kind of abuse a vulnerable adult. So lack of resilience has been noted as a risk factor. The perception of caregiving is burdensome. So if they feel the person that they're looking after is a burden, then they're more likely to not give the best care to that person. The toxic trio, so things such as mental illness, physical illness, substance misuse, those type of things can influence on caregivers' ability. So we know from my gentleman and lady, the gentleman with Parkinson's, her substance misuse was a risk factor for the reason why he was experiencing neglect. lack of support. It's incredibly challenging looking after somebody with dementia or someone with additional health needs. And a lot of carers don't have that carer network or that additional support or respite or that type of thing. So again, if you're at breaking point, you're more likely to not give the best care to the person that you're looking after. And social economic stress, as we all know, we're in a financial crisis at the moment in the UK. And again, these things impact on somebody's ability to give the best care to someone. So when you are assessing adults, then you should absolutely be doing kind of a holistic assessment, considering the patient's emotional, social, psychological and physical presentation. There are some things in a history taking and when you're assessing your patient, what you need to be alerted to what might be a red flag for safeguarding. So things such as inconsistencies in the history or the explanation. If something doesn't quite add up, or the explanation for a possible injury, that might red flag to you actually something more is going on here. And again, bear in mind care homes as well. If an injury doesn't quite add up with what's happened, always think, is this a safeguarding referral? Do we need to take this further through the safeguarding channels? Skin integrity, sometimes it's things like just noticing a pressure sore or a pressure ulcer on somebody could identify that this person may be experiencing neglect. They're not getting the best care that they need to get. Pressure sores, we should be preventing them at all levels. We shouldn't be having patients with multiple pressure sores. Diet and hydration, so assessing, has the person eaten a drink today? Do the care staff have a record when the person last ate? When was the last time they had a drink? If you went to somebody in a care home and they'd not had a drink all day, that should be setting alarm bells off to what's going on in this care home. Is there some institutional neglect going on here? Personal presentation as well. Does the person look unkempt? Delays or obstacles in seeking or receiving treatment. So, for example, if somebody fell at home and they had carers, but they didn't report it till the next day to get that person checked over, that's a bit of an alarm bell to why wasn't it addressed straight away, especially if somebody had a significant injury. Or even things like evidence of not attending health appointments can sometimes be a red flag to what's going to kind of safeguarding. Is there something more going on with this person? So when you're raising concerns, there may be some things that you additionally need to think about in your assessment. So you might want to assess capacity to see whether the patient has capacity about the decision that you're going to make or involve them in. Are they able to give informed consent, or is action needed on their best interest? So again, social services, if you're going to refer into social care, would be really grateful for any information that you can give them around this type of area. Are there valid reasons to act even without the patient's consent? So again, is a patient at risk if they've not consented to a social care referral or a social care discussion? Do you need to act on their behalf? Do you need to act if there looks like there's a service failure where other people may be affected? Particularly around domestic abuse, we need to be mindful that are there children in the property or are there children in the family? Because again, that would need to go for a referral for children's social care. So if you go to a victim of domestic abuse and there are children involved in that family, then that's an absolute kind of social care referral for children's safeguarding. And again, things like, has a crime been committed? Is immediate protection required? Do you need to get the police on board if it's something urgent? And is that person at immediate risk? Be open and honest with your clients and your patients as much as you can. Don't promise to keep safeguarding a secret. Seek consent. It's always best practice to seek consent to share information. And you may share information without consent if it's in public interest in order to prevent a crime or protect others from harm. So when reporting concerns, ensure that you follow your organisations, policies and procedures. Be really concise in the referral so the person who's reading the referral can identify the key issues. Don't delay, try and get those done at the time, because information can be lost if you leave a safeguarding referral till the next day. And make legible, factual and timely, accurate records of what you did and why, to demonstrate transparent, defensible decision making. For example, things like a capacity assessment or a best interest decision. I just thought this was quite useful just to bring into this webinar as well, this kind of notion around the missing person. So the Alzheimer's Society states that there are about 850,000 people in the UK with dementia. 1 in 14 people over 65 will develop dementia, and the condition affects 1 in 6 people over 80. If an adult who has learning difficulties or a condition like Alzheimer's goes missing, it's a police contact in the first instant, and every minute that they're missing increases the chances of them being harmed, and police will always prioritise this. Now, there was a project rolled out nationwide from 2021. It's something called the Herbert Protocol. So I thought this was a really quite a useful thing that you can add into your day-to-day practice. So the Herbert Protocol is a form which is kept safe in a safe place, and it contains important information about a vulnerable person. So it's giving the carers or the family access to this protocol. They can fill it in, they can keep it in the house, and then if that person were to go missing, so the person with Alzheimer's or dementia were to go missing, it's vital, quick information that the police need, because sometimes in those situations where someone's gone missing, family members struggle to recall things on the spot. They're in an element of panic. So having the information ready for someone who would likely go wandering or go missing is just another way to try and keep people safe and get that information to the police as quickly as they can. And it includes things such as vital details, medications that are required, phone numbers, place previously located or attended, photographs, daily routines, that vital information that the police need to piece the clues together to try and find that person. So again, if you've got a client or a patient that you're seeing who's likely to wander, and you've got a caregiver there, just highlight to them, have you thought about having a Herbert Protocol, a form in the house that if they were to go missing, we've got the information there that we can hand over to the police, so you're not in a state of panic and unable to recall things about that person. So, as I said earlier, I worked within a neighbourhood team in a community setting, and some areas will have these hubs, health and social care, under one roof. Not all areas. The areas where I tended to see them more was more in deprivation areas. But again, it differs from where you are and where you work and that type of thing. So if you do get any development time in your professional roles, I would recommend maybe spending some time, if you can, with adult social care or a community team, just so you can understand the process more and see exactly what support's available in the community where you work for vulnerable adults. Now, in the community where I worked, we were all under one roof. We're in different rooms, but we had monthly meetings where we would come together and we would discuss vulnerable adults out in the community. So district nurses are really key on this because they tend to come across lots of vulnerable adults in the community setting. So they will bring some cases, so almost like an MDT, Marek procedure, where you're all sat around the table, everyone brings their cases of their vulnerable adults they want to discuss, and we all sit around the table and discuss each case. We usually get consent first, unless they lack capacity, and we bring the cases in their best interest. And the district nurses will discuss their case, social care will give their input, housing might give their input, the GP might give their input, or you might have an advanced clinical practitioner may give their opinion, and we kind of discuss the cases as a full MDT discussion. And again, this will be happening in your practice areas. It's just finding out the services around you that do this. So we triage cases. We make sure that, that their health and social care needs are being met, and very much under that Care Act of 2014 of that joined up working. Sometimes in the cases that are brought to these types of meetings, it may highlight that they lack capacity and we need to make best interest decisions. And again, we would work very much in partnership for community patients with the GP with this as well. So very similar to the MARAC process, where you're kind of sat around the table, but everybody has a piece to bring to that puzzle to try and get the best care we can for the patient or the vulnerable adult that we're discussing, because safeguarding is complex. And sometimes these cases are really complex and it's not something that you can solve by yourself, but you absolutely need everybody around the table to discuss them, to see a way forward to try and improve the lives for those people. So just to finish off, really, I'm just going to bring your attention to domestic violence. So domestic violence is a high risk issue. As I said earlier, it's not just physical, it's sexual. It can include sexual as well, psychological, emotional, and economic. 2.3 million domestic abuse crimes are reported each year, and 2/3 of them relate to the women being the victim. On average, 2 women a week are killed through domestic abuse, and domestic abuse crime occurs every minute in England and Wales. Around 30 women a week attempt suicide, and 3 women kill themselves each week as a result of being subjected to domestic abuse. 140,000 children live in households where serious domestic abuse cases take place. But again, we just need to be mindful that, similar to the elder abuse, these are the crimes that we know about. There's probably a lot more that are unreported. And again, are these statistics right when it comes to women and, the women being the victim? I'm sure there's just as much male victims. It's just it doesn't go reported. So we just need to be mindful. These are the statistics that are reported that we've got here. Both men and women can perpetrate domestic abuse, but as I said, the majority of known perpetrators are male, and domestic abuse can occur across family and intimate relationships. So it's not always the typical husband and wife or boyfriend and girlfriend. It can happen between brother and sister, or grandfather and granddaughter, or uncle and aunt, something like that. So it's not always romantic relationships. If the people are known to each other and have a connection, then domestic abuse it applies to them. So it's not just romantic relationships. It can be other people in the household as well. So having the conversation around domestic abuse. So generally, people are more likely to confide in a friend or someone close to them rather than a police officer or a professional healthcare professional. We're always taught to never have the conversation if the perpetrator is around. So you don't want to start talking about domestic abuse if the perpetrator's around in the house or sat next to the victim. And the reason for that is that if you question it, then sometimes the abuse can become worse. So we never ask when the perpetrator is around. Try and have the conversation face to face. So if the perpetrator is not in the house or nearby, always have the conversation face to face. Approach the subject with obvious kindness and concern. Let them know that you're there just to help and support. And start off by asking things, like, how are things in your relationship? Is there anything that bothers you about the behaviour of your partner? Those type things. So gradually, gently get yourself into the conversation before you ask outright, have you ever experienced domestic abuse? So if somebody's in immediate danger, then it's a police matter. Again, if there's children in the household or children involved, then it's always a children's safeguarding referral. And don't feel like you have to make this decision alone. Safeguarding, we're never alone in safeguarding. You can always ask for senior support. You can talk to your safeguarding leads. Depending on where you work, you might have access to the safeguarding nurses and that type of thing, or just a senior colleague or a manager. If you're worried about someone, try talking to them and let them know what's happening or where help's available, and always make a clear record. Records are vital. Lack of poor recording has often been cited as a key area for development and safeguarding homicide reviews. So always make a note of it if you suspect it in your documentation. And that's the end of the webinar. I'll stop sharing my screen.